So it was called atypical large mononuclear cells in the peripheral blood. The prominent areas suggestive of leukemia needs further evaluation. Next slide. And we did additional tests on this patient. FAST was positive. Periodic acid shift test was positive. Immunophenotyping showed a CD10-19 dual positivity suggestive of an ALL. The cytogenetics showed that there was no Philadelphia or MLL gene. The fish was negative for 922 and 814. BCR was negative for BCR-ABL. Next slide. Just go back to the previous one, sorry. So on the basis of this, we started off with thinking that larger cytoplasm, prominent nucleoli, myeloid, and it turned out to be PAS positive over here. Not peroxidase. Peroxidase is myeloid. PAS is lymphoid. 1019 dual positivity is again lymphoid. 1333 HLA-DR is myeloid. You just have to remember these 5 things. For lymphoid it is 1019. I'm going to give you a detailed analysis later on. But for a simplistic take-home kind of a thing, 1019 dual positivity ALL. 1333 HLA-DR myeloid. The reason for doing cytogenetics here is that it's an ALL, and if you are getting Philadelphia chromosome positive, it's a poor risk. I need to know that when I'm discussing with my patients here. To spend or not to spend on treatment. If it's Philadelphia positive, expenditure may not be worth it unless they're going for a bone marrow transplantation. Because these people tend to relapse, they don't do it. So you spend amount of money thinking they're going to remission, they might go only for them to relapse. So the whole idea of spending money for remission is so that they can go towards the transplantation. Next slide. Can you appreciate the vacuolation? This was a typical, this is again an ALL, was typical of an ALL L3. And this boy had a mass inside his abdomen. He also had masses inside his kidney. And he was a Frank Burkitt's leukemia, lymphoma leukemia situation. And the protocol for this is a different protocol from that of the ALL. So we had to treat him differently. And therefore it's important to look at the morphology and the radiological features to give an answer. Next slide. Of course, on the peripheral smear, you will have times when you will be stuck with something like this. You will have these large cells which have got a large cytoplasm, very funny, odd looking nucleus over here. But please remember, if you are seeing skirting along the cells, see the dark blue color along the cytoplasm where it is touching the red cells? This is a reactive lymphocyte. So please don't fall for the trap. These are reactive lymphocytes. Larger cytoplasm, bluish in color because of the mRNA inside it. These are virally affected lymphocytes, and these are not blasts. These are actually reactive lymphocytes, and especially if you get the skirting around, please be confident. Next slide. This is the slide I was telling you about. On the peripheral blood, we picked up this vacuolated cells, and we thought that this could be an ALL L3. This turned out to be an ALL L2. There was no masses anywhere else. We treated them like an ALL L3. Next slide. If you were to look at the ALL biopsy, this is what you're going to see. Can you make out much? Biopsies are not good for good morphology. They are good in terms of doing immunohistochemistry, but really it's very hard, and I'm going to show you a comparison between ALL and AML biopsy. Sometimes very hard on biopsy. Morphology on the biopsy, I'm trying to impress on you, morphology on the biopsy is not as good as morphology on the aspirate. Aspirate morphology is much more great. So if you get adequate sample, worth it to look at the aspirate and do whatever special stains. But hard. So sometimes if you don't have an aspirate, you're dependent upon this. You do special stains and you pick up answers. Next slide. I need an answer for this. It's a 52-year-old gentleman who came to us from Bengal. He's admitted for surgery. His platelet count was found to be 86,000. There is no fever, no lymphadenopathy, no organomegaly. But he's presented a fair dinkum Bengali man. And this was his peripheral smear, and the reason of referral to me was for the thrombocytopenia. Can I do surgery or not? Any comments on this slide? They are large platelets. The answer is macroplatelets. There are 2-3 differentials when we look at macroplatelets on the slide. I gave you a history studies from West Bengal. Please remember, for some odd reason, people who come from Northeast tend to have macro thrombocytopenias. Their platelets are large. They are functionally absolutely active. A series has been done by CMC Vellore a long time ago because a large number of Northeasterners go down to Vellore for treatment because Vellore is the place where they would like to go. So the second opinion from West Bengal goes to Bellore.
It's physiological.
Yeah, it's physiological in there. I mean, it's physiological in terms of its clinical behavior. But obviously there must be some pathology causing a macrothrombocytopenia. I believe one of the company guys has done some work on this, and he might throw more light because he's looking at the genetic structure. I'm hoping he will throw more light on it. He's done a large series of tests on northeastern population. What I want to point out to you is that look at the size of this platelet, almost the size of an RBC. The machine is not going to count this. So what do we do next? We ask for a manual platelet count. And sometimes the manual platelet count is much more, and we allowed surgery in this patient because manual platelet count is almost 1,30,000. As per current criteria, we could allow this patient to undergo surgery. Absolutely uneventful. Surgeon happy, patient happy, everyone happy. Sent home with an answer that it is probably a benign ethnic thrombocytopenia. BET. Benign ethnic thrombocytopenia. Yes, Sanjay?
So the platelet count was 86 on the machine, right? And 130 manually. What was the MPV in this?
It came as a dash.
MPV?
Yeah, it came as a dash. It could not calculate. It came as a dash.
No, but if the platelet count is 86,000 and if the MPV is
high,
normal or raised, is it still required to do a manual count?
For me as a clinician to go ahead, yes. Because the guidelines say for major surgery you need X amount of platelets. So I have to write on platelet what the platelet count is, so that I can medically take care of myself.
But if the MPV is raised, isn't that enough to confirm that okay then the platelets?
You'll always have some smart Alex looking up the net. So it's better to document on paper that your intention was to look for the manual platelet count, confirm that it was above 100,000.
Does this mean that every time you have mega platelets or
one of the hospitals
you
where I
do
go
a manual count?
Yeah, one of the hospitals where I go, they don't give the machine value. So if the machine value is something, what comes on the final report is the manual platelet count, and they write down
below 100,000.
Yeah, they give the manual platelet.
You should always do a manual count in all those cases.
It's worth doing a manual platelet. If you have the time and the expertise, I mean, if your lab has that kind of time that you can spend on it, the manual platelet count will take time. But if you have the methodology, it is worth doing it. But that is if the MPV is high. If the MPV is normal, there is no need for you to do it. Because then you are not expecting macrothrombocytopenia. This is to be done where there is macrothrombocytopenia. Your machine is not counting it. Hence you want to count so that you get a higher value and you go ahead with whatever it is. If the MPV comes through and it's normal, you can't do it. For example, dengue fevers. And you can't be doing manual platelet count for dengue fevers. And the labs will go crazy. So I'm not advocating that.
No, but even on the oil immersion, if you count the platelets perfect,
yeah,
you can get approximately
yes,
13, 14, so it is about 1,30,000.
Absolutely. Absolutely. What we were taught in CMC Vellore was that we should count 10 oil fields
and take the mean. That's
and take the mean multiplied by 15. So if you get that, that's your manual platelet count.
So it can be that formula you say
10 oil power fields you calculate away from the tail, not deep inside. So somewhere in the center, in the body, 10 oil fields that you see the platelets, count the platelets, and take a mean of that. So I do 10 because then you can just divide by 10, simple as that. And then multiply that by 15,000. That gives you an approximate manual platelet count.
That will also depend on the how much is the RBC count and thickness of the sphere.
Yeah, sure. That's why I said come to the body side so that we can eliminate that as a factor. Not too deep inside, not too much in the tail. And pick it up. That's a kind of a simplistic way of doing things to see whether it's tallying or not. If it's not tallying, then and if people are like me who want a manual platelet count, you'll have to do one.
Depends on the microscope also.
Depends on the microscope.
Field of vision.
Field of vision.
No, if you have a bigger field of vision,
Yeah.
you get. I don't think that can hold true action.
Sure. Yeah. Those who have got a broader vision.
Yeah.
They go on here.
Count more cells.
Another method is Newbar chamber method for that platelet. Is it worth that to correlate with that or
look, it's like this. If your clinician says we have to do it, we want a manual platelet count, and you want to do that method, you are kind of duty bound to give that report.
which
You
one
can
is
do better
better?
Newbar
Which one is
method.
better? That oil field is better or
No, Newbar.
Newbar is better.
No doubt. Oil field is a subjective, I feel, you feel. Newbar is definitely much more objective. No doubt.
instead when we do we just find out the proportion of RBC and platelet ratio and calculate from the RBC. The RBC count can get very accurate from the machine.
True. But I don't know whether that formula will hold true. I think Srikanth needs to do this. You can work it out. The differential diagnosis in this case can also be a chronic ITP. It can also be a chronic ITP where because of chronicity of the thrombocytopenia the platelets are large. But usually we don't see such large platelets in a chronic ITP. It's unlikely. Third differential in this case could be a myelodysplastic syndrome. So please, when you're getting a macro thrombocytopenia, look at the other cells which are also there. RBCs for anisocytosis and the WBCs for any changes of especially hypogranularity. We'll be able to pick up changes of myelodysplasia. So I'm not saying that all macro thrombocytopenias in a West Bengal patient are going to be benign ethnic. Clinical history and all are also important. Look at the company that the cells are keeping and we can come to an answer as to what it could be. But most likely, if it's an uneventful past history, it's going to be a macro thrombocytopenia which is benign in nature. What else do I do for such people? I tell them get your family also tested. And you might see thrombocytopenia in the family members also. That further confirms your suspicion that this is. And you'll be surprised how often it does not be problem. So it's nice to keep that in mind. Next slide. Now the entire volume has shifted towards this area. And what's going to happen is that in this area, the number of people with the machine is only 27%, the white cell count is 40,000. Next slide. You don't need a tremendous amount of this to know. You can see this? There's a nice hockey stick there. So this is a myeloblast and with an OR rod is pathognomonic of the presence of an AML. If you see here, there's something called an OR body. Can you see this one here? It's not an OR rod, it's a block. That's an OR body. That's also a condensation of OR dots inside, but it is abnormal. It is not normal. So it's not formed a kind of a rod, but this is certainly abnormal. And you might see a few over here, kind of a granularity which is polar. You can see another hockey stick over here. This is a typical of an AML. Next slide. So like I told you, if you have a good CVC and a good smear, you got a diagnosis. You don't need any additional tests. If my patient, just go back to the previous slide please. If my patient was not affording, I would stop here. And if literally in this case we did that. We didn't do a marrow, we didn't do immunophenotype.